Next up, we have Dr. Marisha Burden and Miss Kennethman. And Marisha is the Division Head of Hospital Medicine and an Associate Professor here in medicine. Her primary area of focus is hospital system improvements, workforce models of care, diversity, equity, inclusion. She's got several publications in these areas and is funded, has won grant in those areas. She is a co-lead for a big research network for hospital medicine folks all around the country called the Re-Engineering Research Network, or Home Run. I really like that acronym. She's been on the Home Run Planning Group. She's looked at the impact of adaptations during COVID-19 through that network, also looking at the impact of women in medicine during COVID-19 and workforce priorities. She is a member of the Society for Hospital Medicine and actually recently won the Society for Hospital Medicine Clinical Leadership Award. So congratulations on that. Yeah. And then Ms. Kennison has a Master of Science in Public Health and is currently doing a PhD in Health Information Technology and defends in a couple of weeks, I believe. So thank you for coming and making the time at this time. And she is the director of the Data and Analytics Core for the Division of Hospital Medicine here. And her expertise includes data analytics, research design, qualitative methods, quantitative methods, and mixed method approaches. And in the Home Run Network, she also serves as the lead for the COVID-19 Workforce and Planning Work Group. Her areas of focus are also hospital systems improvement, research design, qualitative and quantitative methods, and she's grant funded in all of these areas. So take it away.
Great, thank you very much. All right, we're very excited today to talk about really our life and work passion. We love to study work, and this talk will be on something we have called gritty work. And the big theme is really how do we build better work structures and environments so that we can actually do the best work when we show up, have the best worker health, and also optimize organizational outcomes. And we believe we can do all three. So we want to do a couple of disclosures. We are really grateful to have a Total Worker Health Pilot Award, and we also have an HRQ funding, which does not pertain to this, but just in the spirit of transparency. And then want to thank Lauren McBeth, who is side by side with us in this work, our incredible Division of Hospital Medicine, who is also side by side with us. And then Angel and I share a mentor, Dr. Richard Albert, who's been a mentor for us for more than 15 years. You guys got to hear about us, but one fun story is we worked together for at least 15 years. We'll not say the exact number as it keeps inching up, but I'm just grateful to get to partner with my research partner in all of this. So we're going to do 4 things. We're going to talk about the wicked problem of hospitalist workloads, and hopefully you can contextualize this into your daily work, whether you're a clinician or researcher or otherwise. We'll talk about using evidence to guide practice, which I would argue that we do not do today. We'll talk about gritty work, our passion project, and future dreams and next steps. The wicked problem of hospitalist workloads. So I love ChatGPT, and so for each section, we're going to have a line. And so the first is on bottlenecks. Bottlenecks cause so much strife, but hospitalists bring back the life. They work with grace, they work with might, making bottlenecks vanish out of sight. Speaking about patient flow and how hospitalists are known for our work and making things run smoothly. So I'm fascinated by work. I love my work more than I probably should ever tell people. But I'm fascinated by what our systems do to our workforce and our ability to do great work. And so I've kind of taken a deep dive, and I won't spend too much time because we only have a brief moment with you all today. But when you look at the history of work, you see some of that history in today's methods for measuring work and understanding work and for setting up work. And what you see today is a real struggle about how do we optimize that to the point where more than 50% of clinicians are burnt out. People don't actually feel like they can actually do good work. So much of this stems from thinking about Taylorism and scientific management and how much can we measure every single movement of every single day. And then you see a progression over time that we start to understand that we also have to take into context. Are we supporting the worker to do their best work? And then you start to see things such as total worker health, which is such a neat concept about building better workplace practices where we're not only measuring, but we're setting people up for success to do the best work possible. So I decided in my mid-career, for better or worse, to go and get an MBA. And so I'm gonna bore you with 2 slides, potentially, to talk about finances. And I realize in medicine, we often don't like to talk about that, but if you don't have a margin, you often don't have a mission. And so I really tried to think about how do we marry the money part, which maybe folks care less about, but you have to marry it with the mission part. And if we don't get all of it together, we really can't go where we want to go. And so if you look at the business perspective on things, the goal in any business, for profit or not, turns out is to make money. And you make it by increasing net profit while simultaneously increasing return on investment and increasing cash flows. And you do that with the goal of making more of it. So in the hospitals world, we're going to think about this for a little bit, but the way you make more money in general to get at those things I just talked about is you have to increase throughput. So you have to increase the number of sales per value of time to get more money. Inventory, you could contextualize that as patients in the hospital. So if you have them stacking up longer lengths of stay, you're not actually getting throughput. And then operational expense is a big cause for concern today because most of that is coming from labor costs. Now in the hospital's world, I would argue there's a conundrum here, and I'm going to show you this in a couple of slides. But when you start to increase workloads to the point of no return, you start to lose throughput and you start to increase your patient numbers, which does not make you a profit. So now we're going to jump to using evidence to guide practice. Here's ChatGPT's version of this, optimizing worker health and job performance. For hospitals, the goal is clear: to advance the science, to build on what's here. With evidence-based practices, they do aspire to make the work they do of the highest caliber. So what we see in the literature of the hospitalist world is that as you start to increase workloads, it starts to negatively impact hospitals, i.e. the worker. It starts to negatively impact their job performance, and it also negatively impacts operations and financial outcomes. So I love this paper. It actually dates back to 2011. It is an observational study, but what they find consistently in this paper and others, and in our own work as well, is that as you increase the number of things done, you start to see increasing length of stay, and you start to see increasing costs from the facility side of increasing costs of more patients and more time in the hospital. So I want to argue that if you look at our operational practices today, like how we staff things, how we think about our clinics, our hospital spaces, there's a lot of lore in how we go about doing this. And I'll use one example, which is in the case of hospital length of stay. Our goal is to get it as short as possible. Patients don't want to be in the hospital, and it's costly when we don't. And then we actually limit care if we don't move patients through the system. I've been in hospitals now for a long time, and I've got to see the same things play out over the years. And the way I've seen us address increasing hospital length of stay is how many huddles can you get in a day to try to bring people together to talk about how we didn't move patients through or what we need to do. The goal is ideal in that we're trying to improve communication, but sometimes we cause disruptions. This charge before noon, we'll talk about that in a little bit, but as a physician or clinician, you're asked to do almost everything before noon. And so you need to see your patients, you need to call your consultants, and oh, by the way, we expect the discharges to be done before noon, at least, if not before. Geography is another solution that's thrown out there around length of stay. It is a really great thing. Studies have not consistently shown that it helps there. Workloads, we see some consistency, and then incentives. Be careful what you incentivize, because some studies suggest it actually increases length of stay. Because if you have a patient who discharges at 8 p.m. and you're incentivized for before noon, what is your choice when the amount of energy it takes to actually get somebody out at 8 p.m. is really rough? So we had a fun study. This was actually funded by HRQ and kind of hit a big Twitter storm this last week, which was really exciting. But we randomized physicians at 3 hospitals to try to understand, does prioritizing discharging patients first work? It's a common initiative. I thought it was actually just common in the United States. Turns out it was a global phenomenon. And we found in that randomized control trial that tactic does not work. And in fact, if you look at the qualitative comments, it may actually be doing some harm. People feel that it causes rework. And so this is a great example of things that we're doing that had no evidence behind them that really makes us kind of pause for a moment to say, how do we optimize our systems to perhaps make them better in an evidence-based sort of way? So I alluded to this study earlier. We know that increasing workload in the hospital's world increases costs and increases length of stay. It is a known entity. What about workload in hospitals' health? We're focusing on burnout and trying to improve how our people are doing. And workload turns out is like a primary driver of burnout. So here's what kind of we're after, to be honest, and this is a great study by a business colleague of ours as well as a physician colleague, Dr. Reba Kara, where they assessed, what workloads do, and they got at what we call the Goldilocks phenomenon of like what's too much and what's too little. People don't want to be underutilized, but there's also a breaking point. And they found that both in community hospitals as well as academic hospitals that they looked at, that they were all kind of short-staffed, but for different reasons. And then if you ran your census a little bit lower, your patient numbers, you actually saw improved efficiency as well as a cost savings of more than $1 million. It was really impressive. We had the opportunity to do a study at 13 academic medical centers, talking to clinicians and leaders to understand what capacity strain does to them. And what we found, again, is there's a high cost to running things really full. And granted, we have to run things really full because a lot of people need our help, but how do we optimize them? And what we heard from these 13 academic medical centers is we keep kind of reinventing the wheel through ineffective strategies that cause a lot of stress. And what people said is that we continually use low yield tactics, and this causes tension and conflict, and then we do it all over again. And this negatively impacts the workforce, patient care, and institutional outcomes. So now we're going to get into the exciting part, something called gritty work, which we hope to actually build evidence into practice, taking the research that we know that we're starting to build and actually putting it into place. And so last rhyme on gritty work, the hospitalist workload heavy and rough, a new app designed to make it less tough. Gritty work, its name, a tool to transform, a chance to improve the ultimate norms. With better outcomes for workers and patients too, hospital operations will improve. It's true. Less stress, less strain, more time to care. A solution so unique, it's beyond compare. So we had two main aims to define and measure inpatient clinician workload and starting to pair it to key outcomes. So we're going to talk about a scoping review, our Delphi panel, and then where we're at on our mobile app called Gritty Work. And Angela is going to take it over after one more slide. And so with gritty work, you'll see is it's our dream is to kind of get past like old work force strategies and to start building a more holistic assessment, rapidly adapting and evolving our workplace structures and environments.
All right. So we have used all of these tools in a variety of different studies, a variety of different approaches that we've taken to understand work. I'm just going to talk about the few that we've applied in our gritty work development. So this is our overall strategy for understanding work structure and what processes drive outcomes, starting with concepts like work RVUs or patient volumes that are most commonly evaluated or considered, and moving out from there to say, like, are these the best measures or are there other measures that we might consider? And so to do that, we started with a scoping review. We use the Joanna Briggs Institute framework for scoping reviews as our overall guide. And our proposed search strategy really sought to understand how work measures are commonly applied or evaluated in literature for physicians caring for the adult medicine patient. And we've gone through 2 initial reviews, and we're starting our 3rd review of the articles that we identified. So to start with, we found 6,434 articles. More than 5,000 of which were considered irrelevant after initial and secondary review. And what we really learned is that there are lots of papers written that include workload as some sort of measure or outcome, but very few clear answers as to what sorts of measures of workload we might consider. So concurrently with our scoping review, we conducted a Delphi panel. So we recruited 17 individuals from across the country in different roles. So administrators, clinicians, researchers, to try to understand from their perspective what might be the most salient measures of workload. And in our first initial qualitative review of our Delphi panel, there were actually 192 individual unique measures of workload. In our second round, we were able to hone that down. There were 6 measures that were considered of that original 192 that were most relevant to understanding workload. And they fell into a number of different domains: well-being and culture, financial measures, and different sorts of scoring systems. So in our third round, we went back to our Delphi panelists and we said, okay, we've got a whole bunch of measures that you couldn't find consensus about. Let's look at those ones again. And we found an additional 25 measures that those panelists felt might be relevant to the exploration of work, and adding in, you know, productivity as a domain, workload in general as a domain. I think though most telling might be the qualitative comments that we collected in that initial round where we identified 192 measures. And what we really learned is that it's workload is multidimensional, and it's important to understand what's sort of within a person's locus of control if you're going to say this is a metric that we're going to hold you accountable to. So takeaways from both our initial scoping review, we still have one more round of reviews to do with that, but initially having reviewed many articles, traditional measures are insufficient. And what we heard from our panelists is that understanding workload probably means more than just measuring workload, but like, what are the outcomes of workload? What are we doing to people? And so truly a more comprehensive and nuanced approach is needed to really understand what we need to be measuring and incentivizing and focusing on. So we actually have a really complex framework that we have developed that has a lot more content than what I'm showing here. It is informed by a number of different other validated measure or frameworks and theories. And this is like the formula that we believe is at the heart of our framework. And so the inputs include work models and environment, plus work processes, and that informs the output of work performance. And that work performance is across domains. So we're talking about work performance that affects patient safety and patient outcomes. We're talking about work performance that you see reflected in the worker's health, and then work performance that affects the institution overall. So that brings us to our beautiful, comprehensive, hopefully nuanced approach to understanding and measuring workload. We are in the process of testing our GradeWork app as we speak. And to develop it, though, we engaged in really robust stakeholder engagement and really robust sort of early user testing, informed by a validated model for user-centered digital development, going through a process of iterative optimization. And so ultimately, though, our overall steps are to develop and test our mobile application that's been developed. We're in the process of testing. With that mobile application, though, we'd like to take that data from other sources and bring it into a platform that then leaders could use in their day-to-day work to monitor, evaluate, and truly make data-driven decisions that support their workers, support the patients, and the overall institution. This is our GradeWork app. It's beautiful. So I'm showing you just a couple of screenshots. There's actually quite a few more. And essentially what we're hoping to do is to collect data, the baseline data, asking people how many patients did you take care of, how many hours did you work today, but then also getting into things that are more passive. How much movement did your job require? And then other things like using the NASA TLX to ask people, what was your perception of your workload? How mentally demanding, how physically demanding, as a part of our evaluation of our GradeWork app, we're going to extract usage metrics. We're interested in knowing, if we ask you to monitor in real time your workload using this app, when are you able to do that? How often are you able to do that? Do we have abandonment of the app? Do you open it and start to do something and then stop? And what do those usage metrics look like? We're going to assess the quality of the data. So how complete, how correct, how concordant in terms of timing, when in your workday are you able to use the app? And then lastly, we'd like to develop processes to pull data out of the EHR. There's actually tons of metadata to show what people are doing in their workday from Epic, for instance. And so do we have to then ask people how many patients did you take care of? How long was your day? Or could we collect that data from the EHR and reserve people's time for those things that we need to have their direct real-time input into. And then lastly, we're going to evaluate the user experience with our app. This is the system usability scale. It's a pretty commonly applied, validated scale for understanding people's experience with health information technology. And now I will turn it back over to my partner for future dreams. She's the dreamer. I'm the doer.
All right, so this is our future dream. As Angela mentioned, we have the app and now we want to build a safety management platform. And it might look something like this, where you can see what the workforce is saying about their daily work. And you compare it to actual patient and operational outcomes. Some of the data at the bottom of this is actual data through a quality improvement effort, and you start to see that maybe there's a suggestion that there are thresholds at which things start to fall apart. And we would really like it to even offer some decision support, which is, a division head could say, hey, division head, or hey, hospital partners, it looks like this is the sweet spot, so let's think about staffing to that. And then recognizing that staffing models are always changing and technology is always changing. This is not going to be like the perfect model for forever. It's going to evolve over time. And we hope that the safety management platform will actually evolve with that, really guiding, division heads, clinicians, hospital partners, whoever, on the best strategy to drive best patient outcomes and best worker and operational outcomes. So next steps and opportunities for us, we are applying for more grants than you can imagine, and grateful to people in the room who helped review some of those. And our dream is actually that hopefully this is successful and helpful, and our passion is to get every single hospital in the States, if not beyond, and then expand to other specialties. We're very curious about clinics and the workflows there. We hear about all the, it's hard no matter where you work in medicine, and so how can we make that better in an evidence-based way? That is our presentation. We're really grateful and would love to hear your feedback. Yeah.
Certain things in your scheme or assessment are outside of your control.
Mm-hmm.
Like length of stay. The hospital's paid for 3 days for MI, 4 days for something else, and there's nothing you can do with it. You just take it, and maybe if you extend that length of stay, make it 4 days for that disease, and it will improve the workload for your physicians. But you're constrained by what the hospital is already agreed upon, or somebody instilled it on your system. That's one thing. And the other thing, and I just wonder your thoughts on that. It's length of stay is one, but there are some other probably parameters that are outside of your control. And that the second thing is you can look at the end of a month on your hospital list and say, you work 10 days today, this month, and you work 10 days. How much money you billed for and how much money the other person billed for, and make some assessment of the workload of what they did. And a final question, 30 years ago, there were no hospitals, and people somehow functioned okay, and for whatever it meant. So I don't know what the change that hospital system brought, and how you looking forward in that.
Yeah.
Sorry for
No, lots of questions. I hope I can keep up with them. So the first, I think the control part. I would argue that there are some things that are in our control, and there are certainly some things that are not. But length of stay, when you reduce workload pretty consistently in multiple studies, time and time again, show that when it hits a certain point and it's not even all that high, the length of stay goes up. And so if you think about your work today, right, you have too much to do today. You either stay up till midnight doing it, or what else do? You put it off till tomorrow. And so, you do the best you can, but if there's only so much you can do in a day and you have a bunch of complex patients, what you see is it gets put off till tomorrow.
And maybe it's a good thing that length of stay is longer.
I would argue as a patient is not good.
Well, and arguably, if we are able to adequately demonstrate that workload is a part of the equation, then payers like CMS will start caring about workload in addition to other things, and incentivize hospitals to consider that as a part of their approach to ensuring that they're not spending more money than they should for what they're gonna get back from payers.
And it's in your financial interest, if you go back to the business slides, to improve throughput. And then the billing, yes, we can capture billing and counter data. We would argue that it may be insufficient. And so we're trying to understand what is it you really need to measure, because it feels like it falls short when you're just looking at work RVUs or encounters. Now granted, you could also say that maybe clinicians could do better at capturing all their work, but it's hard when you have only so much bandwidth in a day. Your concern is that patient. It is less that, oh gosh, I should drop that charge and add that extra 45 minutes in. You're focused on making sure that patient's safe.
And it's multifaceted, arguably.
Oh, sure.
So, we can use data that's readily available to capture one part of workload and then focus our efforts on asking clinicians other parts of it.
And we believe in the hospitalist movement.
We absolutely believe in
Very
the
biased
hospitalist.
on that.
This is true.
So this is a marvelous thing that you're doing. I have one thought, many thoughts came to mind, what I'll ask about, and that is the workload of the ancillary staff. I mean, we read about how nurses on strike. I mean, this has been going for 40 years. The hospital continues to ask the nurses and the supporting staff to do more and more. And yet that's got to contribute to this as well, in terms of length of stay and
I would
cost to the
ask the
hospital.
question too, is what if we got it right on the front end for the first time ever? Because what we saw in COVID, right, is there's like more burnout on top of more burnout. Now we're having to pay even more money to get any human to come in and do the work that needs to be done, right? And so what if you set it up right on the front end where you didn't have to pay like 1.5 or 2.5 times over what the actual cost should be? And then I think we also have to think about how do we structure our jobs where we're all working to the top of our license. I think here as a hospitalist, we have a lot of support in certain ways to really work at the top, but there's still, it's not perfect, right? And if you looked across all different worker types, there's probably some areas that we can improve there. But I think we have to start treating our people right and making sure that their work is actually sustainable so that we stop perpetuating the same stuff over and over again.
And arguably gritty work could be for anyone. We're just starting with hospitalists because that's what we know.
So there's a famous columnist, Art Bookwell, who died some decades ago. I'm sure Boris knows the name, but he had a sign in his office that said, "The beatings will continue until morale improves."
Trying to get away from that.
So,
Any other questions? This is really interesting work, and I hope you'll come back once you've got some pilot data and let us know how it goes. Thank you, everybody.